Care must be taken to avoid hypothermia when examining the critically ill patient. Heat loss in an exposed patient could complicate their care or compound problems associated with hypothermia. Predisposing factors include old age, drug overdose, and cold water immersion or submersion, which could indicate drowning. Clinical features of hypothermia can manifest as mental confusion, impaired gait, lethargy, combativeness, and shivering. Shivering may stop in severe cases, though this would be an ominous sign. However, be aware that shivering may also be seen in those with a high temperature. Treatment of hypothermia should be centered on rewarming and supporting cardiorespiratory function. Select each of the links to find out more. Passive external rewarming is suitable for more stable patients with a core temperature of more than 32.2 degrees centigrade. It involves making sure the patient is dry and covering them with an insulating blanket. This method assumes that the patient has sufficient physiological reserve to generate heat through their own metabolic process. The patient's status, however, still needs to be continually monitored. Active external rewarming requires the use of a warming blanket or forced warm air, which is applied directly to the patient's body. Be aware of the afterdrop phenomenon, where warming of the extremities, as this can cause vasodilation, which in turn can cause a drop in core temperature and potential for cardiac arrest. Active core rewarming is generally used on patients with core temperatures of less than 32.2 degrees centigrade, or those with cardiovascular instability. Rewarming methods include warm humidified oxygen, warm fluids through peritoneal dialysis or irrigation methods, IV fluids, and external circulation through the use of a cardiopulmonary bypass machine. Although these methods avoid the afterdrop as seen with active external rewarming, they are generally only used in extreme cases where specialist advice should be immediately available. Spinal injury accounts for any injury of the spinal cord due to traumatic injury. The cause could be due to car, sports, work accidents, and falls. Injury can occur at any level of the spinal cord, and the level of the injury will dictate which bodily functions are impaired or lost. Symptoms can vary widely, but may include pain, paralysis, and incontinence. Follow the links to learn about the level of injury and the extent of paralysis. Select each of the links to find out more. There are 7 cervical vertebrae in the neck. An injury to C4, depending on the level of severity, may result in complete paralysis below the neck. This type of spinal injury is referred to as tetraplegia or quadriplegia, meaning paralysis of 4 limbs. A C6 neck injury of the cervical vertebrae, though not quite as severe as a C4 injury, may result in partial paralysis of the hands and arms, as well as the lower body. This type of injury would also be referred to as tetraplegia. The thoracic vertebrae on the spine are attached to the ribs and are numbered 1 through to 12. A T4 injury may result in paralysis below the chest and would be termed paraplegia. The lumbar vertebrae of the spine or the lower back are numbered 1 through to 5. A L1 injury may result in paralysis below the waist and would be termed paraplegia. SBAR is a memory tool standing for Situation, Background, Assessment and Recommendation. The tool consists of standardized prompts within 4 sections, ensuring staff are sharing concise and focused information. It allows staff to communicate assertively and effectively, reducing the need for repetition. It is a simple framework that helps prevent vital information being missed during communication. SBAR also reduces barriers to effective communication across different disciplines and levels of staff. Most importantly, it gives you the opportunity to state what outcome you desire from the conversation. Select each of the links to find out more. Start by introducing yourself and then describe the specific situation about which you are calling. Include the patient's name, consultant, patient location, DNA CPR status, and vital signs. After giving the patient's reason for admission, explain any significant medical history. You should then inform the consultant of the patient's background, admitting diagnosis, date of admission, prior procedures, current medications, allergies, relevant laboratory results, and any other diagnostic results. In order to do this, you need to have collected information from the patient's charts, flow sheets, and progress notes. You need to think critically when informing the doctor or other healthcare professionals of your assessment of the situation. This means that you have considered what might be the underlying reason for your patient's condition. Not only have you reviewed your findings from your assessment, but you have also consolidated these with other objective indicators such as the NEWS2 score, laboratory results, and blood glucose levels. If you do not have an assessment, you may simply state that you are concerned. Finally, what is your recommendation? Explain what you would like to happen and give a specific time frame. Any request over the telephone needs to be repeated back to ensure accuracy.